Hi, this is QD Clinic. I'm Jack Cush with Room Now. QD Clinic is brought to you by Room Now Live, occurring in but a few days from now. Room Now Live will be full of interesting people, both in the audience and on stage, and the interaction between the two should be mesmerizing. Today's case, muy Rapida Medicina. Very fast medicines. What? So, saw this lady today. She's 25 years old. She's on hydroxychloroquine. I asked her to come back in because I got her labs back. When I first saw her, she only had a few swollen joints, like 2 knees and maybe a toe or something odd. And she had been called rheumatoid arthritis, and I wasn't certain. She had been on hydroxychloroquine just a week at that point. I continued the medicine, got labs. Labs came back strongly positive for, inflammation, NRA, RF and CCP off the charts, SED rate 125, CRP 111. So she comes back in. She's not doing better after having been on hydroxychloroquine for 5 weeks. She's also taking a nonsteroidal. And the question is, how long is it going to take for her to get the benefit of the medicine? What she needs is a medicine that works faster. She's a mom. She's got 2 jobs. She can barely walk. And the question is, what do you give her when she needs to be better yesterday? I think the first issue is, what are the expectations on the medicines we use? If you need a fast response, well, they're really just a few, right? Steroids work the fastest, but steroids are the most toxic. And will you remember to reduce and discontinue them? I will often use steroids as bridge therapy, either as a single intramuscular injection to get them going, followed by some low-dose prednisone 5 a day, or a tapering dose, a Medrol dose pack, or 20 for a week, 15 for a week, 10 for a week, 5 for 2 weeks, and then hopefully the DMARD's kicking in. But I want them off prednisone, and I don't like using prednisone. I try to find reasons to not use prednisone. If I need something to work faster, then, in the old days, I think David Ridley taught me this from Minnesota, and that was, start them on methotrexate. They're not going to be better for at least 6 weeks, probably 8 weeks. Start them on a TNF inhibitor at the same time. Get approval for 1, 2, or 3 doses or something like that to boost them, get them started. Maybe they can just be maintained. And I think what we were using back then was a few doses of either etanercept or a few infusions of infliximab. And then the patient would be able to continue their job. They were breadwinners, people who couldn't take time off due to a disability, yet they were disabled. How do you help them get over? Pain medicine, nonsteroidals are not going to do it. Steroids have a limited effect. DMARDs will work, but not too soon. So maybe you could use a TNF inhibitor, because TNF inhibitors, I used to say that giving a TNF inhibitor was how to create a born-again rheumatoid, meaning you give them 1, 2 shots or infusions and boom, they're born-again rheumatoids. They want to go bungee jumping and join the Marines. They feel freaking fantastic because you've alleviated inflammation unlike anything that they've tried thus far. And that's not even yet at a complete response, but they have a noticeable response and can resume function. So high on the list for fast response is TNF inhibitors, along with steroids. Next are going to be JAK inhibitors. The JAK inhibitors, I must say, are impressive. The very first time I saw the data on a JAK inhibitor, Pfizer invited me to an ad board and showed me data on a 6-week trial of their new drug that became to be tofacitinib. And I said, what are these knuckleheads doing? An RA trial 6 weeks long? Well, sure enough, there were demonstrably improved responses by week 2. And complete responses often achieved by week 6 or 8 with some of the JAK inhibitors. So JAKs work fast. And if that's in the equation, fast is what I need, muy Rapida, then maybe a JAK or a TNF or steroids. But everything else is setting expectations. Hydroxychloroquine, very few people are better at 4 weeks or 5 weeks. They really need 8 to 12 weeks to get better. Methotrexate, some are better at 6 and 8, but they really need 12. Most of the drugs that we use, in fact, have a peak response somewhere around 12 to 14 weeks, with JAKs being somewhat faster. Even the TNF inhibitors don't have a peak response until 12 to 14 weeks. So again, you need to set expectations with the patient as far as how fast they're going to get better. What did I do in this patient? Started the patient on a TNF inhibitor because, well, that seemed to be the right choice. They had failed other therapies that allowed them to be on a TNF inhibitor. So hopefully we'll see a good response within the next 2 or 3 weeks. That's it for this episode of QD Clinic.